Okay, dear all, welcome back to Nephropathology series. This is our second episode or second lecture. We have Dr. Sarah Hassan, Associate Professor of Pathology and the Head of Electron Microscopy Department, Theodore Belhars Research Institute, Egypt. In this lecture, she will present a topic related to nephropathology titled the Glomerular Endothelial Injury and Thrombotic Microangiopathy, not only HUS TTP. We always, as a clinical nephrologist, see in the pathology reports, in some of the pathology reports, a report that in the case has what is called thrombotic microangiopathy. However, the clinical scenario of the case is not in parallel with thrombotic microangiopathy. So, does the presence of thrombotic microangiopathy in the biopsy always equal clinical thrombotic microangiopathy? This is what we will see with Dr. Sarah now. Sarah, you can start now, Sarah, please.
اوكي. السلام عليكم ورحمة الله وبركاته. I hope you enjoyed this lecture. It was confusing a little bit for having a title for this lecture. The whole issue is somehow debatable. As Dr. Muhammad said, sometimes what is present morphologically is not fully reflected on the clinical scenario. That's why we will talk about this issue today. And our agenda will include a revision for the histology of the glomerular endothelium, and we will have multiple stops to highlight how vulnerable the endothelium is. This means that many direct or indirect causes would lead to endothelial injury. And as we have done the last lecture, we are trying to talk about definitions because definitions are the main or the cornerstone upon which we build up all our knowledge. So TMA will be our today's definition and its relation to glomerular.
We lost Sarah again. I hope that she will reconnect soon and to have a stable internet connection.
Sorry for being disconnected. We'll continue our agenda. Finally, we need to release the bond that was traditionally made between TMA and HUS and TTP because first, the glomerular endothelial injury is a unique structure and has functional characteristics of being fenestrated and have highly differentiated and being a highly differentiated cells that are lining the glomerular capillaries and form the first layer of the glomerular filtration barrier. I think that we have seen this picture the last lecture showing us the fenestrated thin endothelium that are highlighted with the red arrows. Immature glomeruli and healthy glomeruli as well, the endothelium should have fenestrations that have no diaphragms, while in the immature or embryonic glomeruli, these fenestrations have diaphragms. So what are these diaphragms? These diaphragms are just like the thin membrane that are shown here are normally present between the podocytes and are normally absent in the fenestration of the endothelium. In glomerular endothelium fenestrations, the lack of these diaphragms enables a high fluid flux driven by the hydrostatic pressure through these fenestrations with a negligible resistance to the water permeability. The average diameter of these fenestrations is 70 nanometers, which is actually more than the albumin molecule diameter or dimensions. So how these albumin molecules are prevented from being filtrated to the urinary space. This is due to the presence of a glycocalyx layer, which actually decrease the size of these fenestrations and thus lead to restriction of albumin filtration. Then we will talk about the regulation of the glomerular endothelium. Actually, the glomerular endothelium are regulated by the vascular endothelial growth factor alpha, which is normally produced by podocytes. Whenever there is an injury to podocytes in any of the glomerular diseases, this vascular endothelial growth factor secretion will be affected, and thus will lead to glomerular endothelial affection. So this is an indirect cause of glomerular endothelial affection. Some papers were talking about podocyte injury, for example, in MPGN, where we can see a podocytes injury. So in this case, endothelium will be affected with this indirect cause. Let's see this electromicrograph or electron microscopic picture for a real case of immune complex mediated membranoproliferative GN. Let's remember what we were talking about the last lecture. Can anyone tells me what is the cell that is highlighted with the red arrow? Let's remember what is this.
Please answer in the chat box. What is the cell pointed by the red arrow?
And also and also the blue arrow and the black one. Any thoughts about this morphology?
Yes, we have comments regarding the red one, neutrophils. Okay, and we
Okay.
have endothelial cells, and the blue is podocytes.
The red is a neutrophil, is polymorph, right?
Yes.
The blue arrow is pointing to podocytes,
Right.
podocytes that are near to normal, while the black arrow points to effaced podocyte, which means an injured podocyte. So we have a polymorph, normal podocyte, and effaced or injured podocytes. What are these? Can anyone tells us what are these rounded, nearly black, rounded things?
In the chat, they are saying that they are deposits.
What?
Deposits,
They
immune
are what?
deposits. Immune deposits.
Right. These are immune complex deposits, and this is an immune complex mediated MPGN. So these are immune complex deposits. And what is in the red circle is a place where immune complex deposit was resorbed, or in other words, dissolved, and it leaves a gap just like that. So in this example, we have two sides where the endothelium is nearly normal, thin, and fenestrated, pointed to with the yellow arrow, and on the other side, an endothelium that is more thick and non-fenestrated, pointed to with the red arrow. The yellow one is a preserved, and the red pointed the area pointed with the red arrow is the injured endothelium. So here we don't have a direct cause for the endothelium injury, but according to the study, the podocyte injury in the case of MPGN causes affection of vascular endothelial growth factor release and a secondary affection for the endothelium with loss of its fenestration. Okay. We should mention that in healthy kidney, glomerular endothelium turnover is low. With cell tracking studies demonstrated that there is no change in cell number or distribution over 10 days. So they are nearly static cells. And that's the case for most of the differentiated cells like podocytes. Most of the differentiated cells are nearly static cells. So this means that they do not proliferate. In response to increase in vascular endothelial growth factor production or endothelial injury, the glomerular endothelial cell number increases up to 4 folds. So they proliferate in response to injury. And these rates of proliferation are the highest in the first 10 days, and even after treatment, clonal clusters of these endothelial cells will be present for 1 to 2 months post-treatment. In response to endothelial injury, a great percentage of diaphragm fenestry similar to immature glomeruli will be present. So normally there's no fenestration, diaphragms between the fenestrations, but with injury there will be diaphragms in the fenestrations, and this will lead to a decline in the glomerular filtration rate, okay, because there will decrease in the water permeability that was in the absence of diaphragms is with negligible resistance, but now with the loss of fenestrations or with the presence of diaphragms will be more resistance and decline in the glomerular filtration rate as general pathogenesis for multiple kidney diseases with endothelial affection. Notably, there is an emerging evidence that endothelial cell injury and potentially endothelial cell fenestration loss would be the first change or the earliest change in many glomerular diseases that may have a crosstalk affection and lead to podocyte damage, and this is the opposite of the concept that we have mentioned a few slides before, that the podocyte injury is the start that will affect the endothelium as a second target. So I think it's just a crosstalk between both, and whenever one is injured, the other will be affected. Am I clear till now, Dr. Muhammad? Any comments?
Yes, Sarah, but can I ask a question? You mentioned
Okay.
that endothelial injury can occur if there is increased level of endothelial growth factor, right?
Endothelial injury occurs with an increase in vascular endothelial growth factor production.
Yes, or with the decrease of endothelial growth factor production. Which of them causes
I think
injury?
it's the vascular endothelial growth factor is I can tell that it regulates the endothelium, so it should be at a certain level, not more and not less.
Okay, what are the causes that may cause increase or decrease in the level of this factor?
The local cause here in the glomerulus is a podocyte injury, which is the source for the production of the vascular endothelial growth factor alpha. Okay.
That's why the podocyte injury may cause endothelial injury, and vice
yes,
versa.
With a crosstalk between both, because vascular endothelial.
How endothelial injury may cause epithelial injury?
May cause a podocyte injury.
What is the mechanism?
Let's go back.
Yes, this slide.
It's a hypothesis. It's a hypothesis. They said that it could be a crosstalk, when there's as with the vascular endothelial growth factor affection causes this. They thought that the opposite can occur.
Okay. Okay, thank
I
you.
don't know exactly what is the mechanism is, but I think that's possible
Okay.
because it's across two. Not all the pathways are fully understood till now.
Okay, thank you. It's clear now. You can continue, please.
Okay,
Okay.
let's continue. So let's describe what is this. Can anyone tell us what is this? I think, as we have mentioned, that this is a loss of the glomerular fenestrations, and it's just now a continuous layer of thick endothelium. So it's an injured endothelium. It's thick with loss of fenestry. Let's see the other picture. Let's describe. It's a glomerular endothelial injury again, but with thicker and also loss of fenestration of this endothelium. So can we say that it's a grades, thick and more thick? It could be said like that. And now we'll go through various renal diseases or examples of various renal diseases with glomerular endothelial injury. Let's talk about transplant rejection, endothelial injury in transplant rejection. When we are talking about glomerulitis in Banff scoring, score G, what is the definition of glomerulitis? Is a degree of inflammation with glomeruli. Glomerulitis is a form of microvascular inflammation, MVIs, and is a feature of activity and antibody interaction with tissue in antibody-mediated rejection. It can also be seen in recurrent or de novo glomerulitis, glomerulonephritis, sorry, which must be excluded by appropriate immunostains or EM. So it's an inflammation of the glomerular capillaries. According to Banff scoring, this is determined by what? By the proportion of glomeruli affected or the percentage of glomeruli affected with glomerulitis by this definition. Let's consider this definition carefully. Complete or partial occlusion by what? Of one or more glomerular capillaries, of course. By what? By just leukocyte infiltration? It's a glomerulitis, it's an inflammation. No, the endothelium injury should be present as well. So it's a glomerular capillary occlusion by leukocyte infiltration and endothelial cell enlargement. Both endothelial cell enlargement or the endothelial cell injury or targeted endothelial cell by virulent leukocyte must contribute both to the occlusion of the glomerular capillaries. So the endothelium injury here is crucial in the definition of glomerulitis. The second item is the main item of the lecture, which is TMA, endothelial injury in TMA. TMA is predominantly related or initiated by endothelial injury, leading to activation of a coagulation cascade. So it's that's the general definition of TMA, which is thrombotic, which means coagulation. Microangiopathy means small vessels. So it's initiated or related to endothelial injury. Again, let's revise this picture. Thick endothelium, injured, thicker endothelium with more injury, or let's name it a severe form of injury. The glomerular endothelium will be ballooned and proliferating, as we have said that it's quiescent or cells that's not proliferating in the healthy and non-injured state. Whenever there is an injury, it proliferates, as we can see here. There are multiple nuclei. It's a nucleus and nucleus and nucleus. All these nuclei are proliferating endothelium, and they are also ballooned. Where is the lumen? Can anybody see here a lumen? No, there's no lumen here. The lumen is occluded by the proliferating and ballooned endothelium. So it's something like a grade of injury according to the thickness and the ballooning of the endothelium cell. Many of us, especially pathologists, may hear about the term subendothelial flocculent material that are present in the cases of TMA. What is subendothelial flocculent material? Simply a plasma protein that leaks under the injured endothelium, as that is pointed to the area pointed to the by the black arrow. Normally, this potential space is not present. Whenever the endothelium is injured, the plasma protein leaks under the injured endothelium here to make a space between the endothelium and the glomerular basement membrane. That's the glomerular basement membrane, this podocyte, and that's the endothelial, subendothelial flocculent material that accumulates in this space. The red arrow points to the injured endothelium, and this is the subendothelial flocculent material. Finally, when the endothelium is injured, as we have said, the coagulation cascade will start and lead to glomerular capillaries, fibrin, thrombi, as seen here with this light microscopic picture. That's the full-blown TMA with the fibrin thrombi, and under the electron microscope we can see here this the fibrin tectoids, which are seen under the electron microscope in the cases of thrombosis. Whenever the acute TMA heals, these thrombi will recannulate, and something will occur for the glomerular basement membrane. It will heal with double contouring that are seen here with the bus stain, which is seen also under electron microscope by this formation of the new glomerular basement membrane. That's the old one. Podocytes here are lost. That's an interposed or interposed cell between the main glomerular basement membrane and the newly formed one, and double contouring occur, and all of this layer is the injured endothelial layer. So the evidence of chronicity will be finally present. Let's summarize again the sequence of events of TMA. First, endothelial injury, then accumulation of plasma-derived material, which is a subendothelial flocculent material in the subendothelial space, plus coagulation cascade that will be initiated. Then an irritation for the glomerular basement membrane will occur, forming a new glomerular basement membrane material, which ends up with the double contouring of the membrane, and that's the chronic stage, which is named chronic TMA, which is actually just an MBGM pattern of injury, but without hypercellularity. So what's TMA again? TMA, thrombotic microangiopathy, is a morphologic description with multiple underlying etiologies that initiate endothelial injury. Till now, anyone needs to ask any question?
Yes, Sarah, we have questions in the chat. We have a question. Please explain fibrin thrombi in light microscopy. Can you point for them again? How can you yes. How can you
Okay.
identify them in the light microscopy?
Actually, here, can you see the lumen of these capillaries?
Occluded.
They are all occluded. They are all occluded by these thrombi. Maybe if we have another stain, it could be more evident, but actually I don't have just H&E stain.
Which stain, in which stain the fibrin
We
thrombi
can
are more evident?
actually, I think that Mason will be more accurate, but I didn't have one for now. But for this picture, can you see any patent lumen?
No.
It's not patent, and it's occluded by these thrombi. Also, BOS will be more good for this, for identification of these thrombi. I'll bring you some of these pictures in later on with the next lectures.
We have another question. Basement membrane has a rule infiltration system or only supports the epithelium and endothelial cells?
the glomerular basement membrane has a major role in the infiltration.
Yes.
Of course, as we will see later on in glomerular basement membrane affection in Alport syndrome, or in cases of vasculitis, when there is a disruption, we'll have hematuria and proteinuria and so on,
Okay.
because of the affection of the filtration of the glomerular basement membrane.
Another question: which stain showing the fibrin thrombi best? You said the silver and pus stain, right?
The Mason stain,
Muscle stain. Sorry. The last question: can you explain, please, again, subendothelial deposits in TMA?
subendothelial deposits.
In TMA.
Explain it's how does it how it form.
Yes.
When the endothelium is injured, as we said,
Hmm.
the plasma proteins will accumulate under the endothelial under the endothelial under the injured endothelium
Oh,
in the potential space here. Let's go back to the picture. When the endothelium is injured,
oh,
plasma proteins leak under the injured endothelium here in this space, and forms this fluffy material, which is called the subendothelial flocculent material.
okay. So to make it clear, it is not deposits. It's not antibodies.
No, it's not a it's not
Okay.
deposit. It's a plasma.
Yes.
It's a leak of a plasma protein.
Okay.
It's not deposit.
You can continue now. Thank you.
Okay.
Okay.
Okay. So let's go back to the causes of TMA. First, these causes initiate endothelial injury, as we have said. The first two causes are the most famous ones, which are typical HUS, chegatoxin induced, and TTP, which is due to deficiency of adamantis 13 or autoantibodies against it. But other causes are present, even more frequent than these typical causes, which is a typical HUS, complement dysregulation, and various drugs, as seen eye toxicity of in cases of renal transplants, scleroderma renal crisis, and malignant hypertension, eclampsia and pre-eclampsia, and antibody-mediated rejection, as we have said, causes also endothelial injury. And TMA could be just secondary to antibody-mediated rejection. So all the causes in this list are causes of endothelial injury, not just typical HUS and TTP. So if we have a case, a report, nephropathology report, for a case reported as TMA, and one of our colleagues of nephrology have this report. To agree with this report, he should have the triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, and diarrhea if diarrhea positive, typical HUS, neurological system symptoms if a case of TTP. Am I right, Dr. Muhammad? You should see this triad to accept the report as being describing a TMA in the case.
Yes.
Right?
Right. Yes.
Okay. But there's another point of view, which is a nephropathology point of view. From our point of view, any direct or indirect cause of endothelial injury, the mentioned cascade will start and will be evident at the level of EM by the injured and balloon endothelium, as we have seen, or even at the level of light microscope if it is more aggressive. And if the endothelial injury is severe enough, coagulation cascade could be activated. So it could be the cascade could stop at any of all the mentioned level. It could be only endothelial injury. It could be endothelial injury with some sub-endothelial flocculent material with early glomerular basement membrane double contouring. It may even have fibrin thrombi, and if it's more and more severe, it may end up with glomerular infarction, as in cases of eclampsia or preeclampsia that may end up with cortical necrosis. So, what about the clinical picture in different causes of endothelial injury? Does the triad should be always present? And this is a question for you, for the nephrologists. Does this mean that the triad should be present in all the levels of this cascade? Actually, I don't know the answer. I need to correlate what I see with what you see in these cases. And if anybody have an answer, I'd be grateful to hear this answer. Okay. So this sequence of events is the sequence of events of TMA, but morphologic evidence of endothelial injury and coagulation cascade does not necessarily mean an underlying etiology of HUS and TTP, and we should unbond them from each other, as we have mentioned in the agenda of this lecture. So HUS presents as TMA morphologically, but not all patients with TMA morphology has an underlying HUS. TMA is a morphologic description and could be due to many underlying etiologies. Let's discuss a paper that was published, I think, in 2021 about infection in patients with suspected thrombotic microangiopathy based on clinical presentation. This paper, this study, discussed Shiga toxin-induced infection and Shiga toxin-induced unrelated infection, epidemiology, and major outcome regarding death, acute dialysis, and major cardiovascular events. And they considered that, in contrast to Shiga toxin-associated E. coli infection causing hemolytic uremic syndrome, the Shiga toxin unrelated infection associated with TMA are less characterized. This study included 560 patients with clinical suspicion of TMA, and they found that Shiga toxin E. coli, Shiga toxin secreted E. coli patients represented only 35% of these patients, of the 560 patients. And the Shiga toxin unrelated infection represented 145 on patients. And patients with no infection and TMA represented 350 patient out of the 560 patients, which are the main number of these patients in this study. And they found that infection were present in 30% of patients with TMA, and most of these patients were Shiga toxin unrelated infection and not an Shiga toxin related HUS. And the most frequent bacteria was for Enterobacteria and Staph aureus, and some viruses, Epstein-Barr virus and cytomegalovirus, mainly in transplanted patients. They found that infection could be a sole cause of TMA or a trigger among other causes. And this Shiga toxin unrelated infection have a major effect on the risk of death, AKI, and even after adjustment of the cause of TMA. And for this point, I see the importance for correlation or correlating what we see morphologically. And when we say that this is a patient with an infection but has endothelial injury or any of the stages of TMA, even full-blown or not a full-blown TMA, this should be reflected on the management of this patient for the sake of this words, which is that this infection have a major risk of their death or AKI, or as this study mentioned. So now I present two cases, and the two cases are real cases, and both have infection-related glomerulonephritis with endothelial injury. One with a milder form of endothelial injury, and one was with a more severe form with full morphologic picture of TMA with glomerular infarction. Case number one was for a male patient, 11 years, and he's had a history of tonsillitis 1 week before the renal biopsy and presented by hematuria and with a serum creat 9.8 that goes down to zero point 0.9 after 4 sessions of hemodialysis. And the other case was for a male patient also. He was 7 years old and history of upper respiratory tract infection 1 week before the biopsy, presented by hematuria. Serum creat was 4.8 that could go down to 1.8, C3 8.2, and C4 8.8. Case number one had 16 glomeruli in his light microscopic examination. All his glomeruli showed mesangial matrix expansion with hypercellularity, segmental endothelial injury with fragmented RBCs, and few endocapillary neutrophils. And we should mention the few endocapillary neutrophils. It's not a classic acute post-infectious glomerulonephritis with many neutrophils, just few endocapillary neutrophils. And the main issue was the mesangial matrix expansion with hypercellularity, which should be the picture of regressing acute post-infectious GN, but which is not classic, is the segmental endothelial injury and the fragmented RBCs, which was evident in this case. And one glomerulus showed cellular crescent, and an early glomerular basement membrane double contouring was present, and segmental tuft sclerosis in one glomerulus was present as well. The other case had 30 glomeruli in his light microscopic examination. And again, all glomeruli showed the messenger matrix expansion with hypercellularity and segmental endocapillary proliferation, also by few neutrophils. Endothelial injury again was present with fragmented RBCs, and this case had 2 glomeruli with hemorrhagic infarction and single glomerulus again with segmental tuft sclerosis. So, can we comment on this light microscopic picture? Can anyone comment if the capillary lumen are the capillary lumina patent or occluded by endocapillary proliferation?
In the comments, we have
They are pointed with a round red circle.
yes, we have some said patent and some said occluded.
Mostly they are patent.
Yes.
Mostly are patent. See this red circle: patent, patent, patent.
Most of the comments said patent.
Most of the capillaries are patent. So what's abnormal? The abnormal is here, the mesangial matrix
Yes.
expansion with the hypercellularity.
Yes, we have this comment
What's
also.
abnormal? What?
Some said mesangial proliferation, yes.
Okay. Another picture for the same case showing an endocapillary occlusion. The capillary is segmentally occluded here, but by what? Can anybody see many nuclei or just ballooned or a fluffy capillary lumen?
Fluffy capillary lumen.
Yes, because it's mainly an endothelial injury. It's mainly an endothelial injury and not proliferation by leukocytes.
Yes. We have a question in the chat box. Do endothelial cells need electron microscopy always to be assessed? I think you answered this now by showing the previous light microscopy, that endothelial injury can
Yes.
be seen by light microscopy too.
Of course, could be seen by light microscopy.
Yes.
But okay. So what is this? That's a crescent. As we have mentioned, that this case had one crescent out of 16. And for case 2, we had, as we have said, a glomerular infarction. So he had 2 infarcted glomeruli. Let's see the electron microscopic picture.
Can you point or explain more how this glomerulus appears as infarcted glomeruli? Can you explain it? Sarah? Sarah, we lost your voice. You are talking.
Muhammad,
أيوة. Yes, we hear you now. Can you explain this slide, please? This slide microscopy.
it's simply a ghost. Okay,
Hmm. You
it's
you mean
a ghost.
you mean it lost its shape or what?
No, it preserves its shape. It preserves the shape of the tuft, but we cannot see the details as we see it clearly with a patent lumina, and the mesangium is forming the stalk that surrounded by glomerular capillaries. It's just a ghost. It's just a ghost of something that was here, but with loss of its details. Only some RBCs that are present in the pastly present lumina, but we cannot see the details. If we can here for this glomerulus, we can see some details. That's mesangium with the mesangial nuclei, so we can count these nuclei. But here, no, everything is going just like yeah, I'd like to say it in Arabic, but it's
Say it
just
in
a
Arabic.
ghost.
Okay.
سايح.
Okay.
كله سايح.
Huh.
No details, no details. In histopathology, they used to teach us and say that it's a ghost.
Okay. There
Okay.
is a question how to differentiate this from nodular glomerulosclerosis. I
Oh,
think
it's
the shape is totally different.
totally different. Yes,
Yes.
totally different. Nodular mesangial glomerulosclerosis means that means an expansion of the mesangial matrix.
Yes.
So the mesangium stands alone and says, "I'm here." But here, there's no details. Everything is going inside the other. No details.
Okay.
Okay.
Yes, you can continue, please.
Let's see the EM. The red circles points to what? Proliferating endothelium. So here was supposed to have the lumen, but it's now just it
Sarah, you lost your voice.
thin
Sarah,
white
can you
remnant of the lumen.
repeat?
The
Can you
lumen here
repeat
is
again?
included by the proliferating basement membrane, and that's the endothelium. Okay, that's sorry, the epithelium or the podocytes. Okay. Okay. First, when you see, okay, can you hear me clearly?
Yes, I can hear you now.
Okay. First, any electron microscopic picture, we should orient ourselves. Where are we? That's where the lumen was supposed to be present. Where is the lumen here? The lumen is totally occluded and leaving just this white space, the white line, actually. The lumen has gone. Why? Because the endothelial cells have proliferated. That's an endothelium cell, that's an endothelial nucleus, and that's an endothelial nucleus. So 1, 2, 3 proliferated, and this I don't know, it looks like an apoptotic cell. So that's an proliferating endothelium that occluded the lumen, and that's the glomerular basement membrane, and outside the effaced podocytes. Okay. So this case, the both cases had injured endothelium under light microscope, and both have a similar or nearly similar electron microscopic picture with injured endothelium. The first picture shows what? Showed sign of injury, which is proliferation, because normal endothelial cells do not proliferate. Another picture shows what? The thin the thin red arrow points to. Can anyone tells us what is this? And the thick one, also the thick arrow. Anyone would like to answer the question?
We have no comments, and I don't know actually.
Hmm?
No comments, and I don't know what is
No
this.
comments.
There is
Okay.
apoptosis. Is it some?
No, no, that's a hump.
Okay.
The thin one shows us the hump, and the thick one shows us the polymorph.
Mm.
So this is a polymorph or neutrophil inside lumen, and that's a hump. And these are with the red circles. These are endothelial cells that are injured, ballooned, and proliferating. Okay, so we cannot see here any lumina. That's a podocyte, and that's a subepithelial hump. And all of these are effaced podocytes with an underlying glomerular basement membrane, supposed to have here a thin layer of endothelium and a lumen here, also here, and also here. But actually, all the lumina have been lost. Why? Because the endothelial cells are injured, ballooned, and proliferating. And here the endothelium is blocked by this neutrophil. Okay, this picture is clear now. Let's go to another one. Again, let's orient ourselves. This is podocyte, and this is a glomerular capillary, and this is another glomerular capillary. But both are occluded by what? This is subendothelial flocculent material. All this space is subendothelial flocculent material because the endothelium, which is this layer, is injured with a leak of the flocculent material or plasma protein, making this subendothelial flocculent material. And again, these are podocytes, effaced podocytes, and that's another subepithelial hump. Okay, I think the pictures are a little bit difficult, or is it clear now?
Clear.
Okay, so till now we had two humps, which means that this uh, this case had what? Had an infection related GN. Okay, two humps. By the way, infection related GN or post infectious even classic, the humps are usually few. It's not you should not have so many humps to say that that's a post infectious GN. Blacks, you should have few humps, not so many humps. Okay, another picture for the same case with what? With another subendothelial flocculent material and injured endothelium with loss of fenestration and thickness. And here another injured endothelium with loss of fenestration and thickness. So another picture, that's all of this is glomerular basement membrane. Can you see how thick is it now? And that's the remnant of the Newman, and that's podocytes, injured podocytes. How thick this glomerular basement membrane? It is very thick. Why? Because that's another and newly formed new layers of the basement membrane. New layers of the basement membrane will be laid on due to the irritation. For our colleagues that asked about the role of glomerular filtration, glomerular basement membrane infiltration. What do you think now? If the glomerular basement membrane that used to be thick and breathy and uniform transformed to this picture, what about the filtration? Would it be normal? I think no, it should be totally altered because the glomerular basement membrane lost its morphology, and whenever it lost its normal morphology, it will lose its normal function as well. So if we go back to revise the back pictures of this case or these two cases, we'll find that the main issue here is the endothelial injury, the endothelial injury with proliferation. Just one neutrophil, or this means that the inflammatory cells are few, and the main issue is for the endothelial injury. So the main pathogenesis here who have been done by the endothelial injury and not by the inflammatory infiltrate. So from my point of view, this picture is of non-Shiga infection, non-Shiga related infection, glomerulonephritis, as was named by the papers that we have discussed, with marked endothelial injury in case 1, and secondary to TMA, full-blown TMA with glomerular infarction in case 2, and active cellular crescent in case 1/16, and both cases had secondary focal segmental glomerulosclerosis. 1/16 and 1/30 in case 2. And that's the end of my talk for today. I hope it was clear as much as I can. And any questions?
Thank you, Sarah. Yes, I have a question regarding the last two cases. Which of these cases have a had a clinical TMA? The two cases.
None of none of them.
None of
None
them
of them.
had a clinical TMA. Both of them
None of
just
them.
have a pathological TMA, right?
Yes.
So
Uh,
so
uh,
so I think that the message that you
third case I didn't. Okay.
third case you didn't mention. You can continue. Yes.
Oh, yes. This patient
Mm.
had a history of gastroenteritis.
Okay.
He was a kid of 7 years old,
Mm.
kid, and presented by AKI
Mm.
and reported to have thrombocytopenia in one of his labs, but it was not the main presentation. Okay.
Okay. So the main message. So
his
yes.
م-
Yes.
م. اتفضل.
كملي يا سارة اتفضلي.
uh, this patient had thrombocytopenia in one of his labs, but the triad of TMA, of microangiopathic hemolytic anemia, and thrombocytopenia, and AKI, he had AKI, but thrombocytopenia was just reported once, and the main issue was in AKI. Serum creat, I think, was 5 or something like that, and was going down very slowly. The main finding in his biopsy was AKI of acute tubular injury, and the glomeruli were totally normal, and another biopsy was taken and was reported to have one glomerulus had an evidence of fragmented RBCs and endothelium injury. Just one glomerulus in two adequate biopsies. So for histopathological report, it's team A. It's a team A, but clinically, it's not. It's not a picture of team A.
Yes. Infection itself can cause thrombocytopenia away from team A.
Okay.
Okay. So
Mm.
the two cases you mentioned didn't none of them had a clinical team A, and both of them didn't treated didn't the physicians didn't treat them with the plasma exchange or whatever, just treat the infection, right?
Yes, I think these patients were treated as infection-related glomerulonephritis, and I think that my nephrologist colleagues refused the term of TMA, and yeah, as we have mentioned, it's not a case of
Yes.
HUS. Why we are
Be,
we are
yes,
why
because
this patient had a TMA?
we as a clinical nephrologist always thinking of team E as a clinical presentation, not a pathological terminology. So I think
okay.
that the main message you are trying to deliver today, that not that pathological team A is not always equal clinical team A, and the pathological team A, in absence of clinical evidence of team A, doesn't always guarantee to do plasma exchange for the patient, right?
Uh, do or do not, yes, it's not an HUS, I don't know what is the actual management should be, but it's not what I would like to tell is it's not an HUS, it's a TMA, or it's an endothelial injury secondary to the present infection, or secondary to the present hypertension, or whatever. What I would like to say, it's not just to deliver the message that I have a morphological TMA. What I would like to deliver is please, if you can correlate more with these patients and tell me if the patients that shows more endothelial injury in an infection scenario, in an infection related scenario, should be treated aggressively or with something, I don't know what is it. I will continue to tell you in my reports that this patient had endothelial injury. No, he has more. He has more endothelial injury in this case, and infarction in another case, and so on. Or no, this term is confusing. I cannot translate this term in the as a management. But from the literature, I saw that it should be translated to something in the management, and that's what I want to deliver, or just to put an eye on these patients to know what is the prognosis with these patients, in contrast to the classic post-infectious GN that may even be not biopsized and had no biopsy for their kidneys.
Okay, we have some 3 or 4 questions, and then we will close this session. Injured endothelium can be sometimes be misdiagnosed as thick basement membrane. Could this happen? Injured endothelium may be misdiagnosed as thick
No,
basement membrane.
no, with experience, it will not be
Yes,
misdiagnosed,
I think
especially we
these.
use special stains. And
Yes, I think this is very easy for the pathologist. If we can revise the picture of electron microscopy, dear doctor, the lecture will be uploaded in YouTube, and you can watch it again and revise every slide in it. Can you differentiate between TMA secondary to malignant hypertension and secondary to infection based on biopsy? Is there a pathological criteria to differentiate?
the presence of deposits, as we have mentioned, the infection in these cases
Yes.
was reflected by the humps, by C3 mainly deposits, or C3 and IgG deposits in immunohistochemistry. We didn't use the slides of immunohistochemistry in this lecture, but later on we'll show these slides. So the presence of immune deposits are the main difference between both.
The last question, do you follow TMA case recovery by second biopsy? I will answer from the clinical point of view. If it is a clinical TMA, we don't follow with the second biopsy. Even we don't do a first kidney biopsy. The TMA is usually a clinical diagnosis. If there is a clinical presentation of TMA, rarely we need to do a biopsy at first presentation. If there is a full-blown TMA, thrombocytopenia, microangiopathic hemolytic anemia, acute kidney injury, schistocytes, actually we started treatment without kidney biopsy. And for sure, we will not follow the recovery by a second biopsy. If you are asking about TMA secondary to infection that Dr. Sarah mentioned, I don't think that we have to also to do a second kidney biopsy, just clinical and laboratory markers. Do you agree, Sarah, or you have another comment?
I need your biopsies, Dr. we all need your biopsies to learn and go on. Actually, TMA, just like lupus, is a clinical decision, or the clinical diagnosis, of course. But as we have said, the debate is what we see under the microscope, and if it's reflected or not, and it's not always reflected. Actually, it's not always reflected.
Okay, thank you, Sarah, for this great and excellent lecture. And we will see you next
You're
month,
Muhammad.
inshallah. Yes, for episode 3. Thank you again. Thank you all for your attendance, and see you later, inshallah. Goodbye.
إن شاء الله. مع السلامة.